Well, settle in with a cup of coffee. It's a fairly long talk about the optic nerve and the retinal nerve fiber layer changes in glaucoma. As someone who's a visual learner, I really like to see pictures, and so I have 80-some pictures in this talk that'll hopefully portray for you what the optic nerve looks like in patients who have glaucoma. Well, we know that the nerve cupping is the unifying feature of all forms of glaucoma. And while other insults to the optic nerve result in ganglion cell damage and pallor, only glaucoma leads to excavation or cupping. And I'll put a little asterisk here because rarely arteritic anterior ischemic optic neuropathy can lead to cupping, but that would be a very tiny percentage of people who have optic nerve head cupping. The changes that we see in the optic nerve generally precede visual field loss. And you can lose quite a bit of your nerve fiber layer and have quite a bit of optic nerve head damage before the visual field shows any loss. So optic nerve head examination is critical in the care of patients with glaucoma or in determining who's a suspect for developing glaucoma. I think most of us would say that the best view is through an indirect lens at the slit lamp. The direct ophthalmoscope lacks stereo. It's very magnified, and I think for an ophthalmologist is not a great tool for looking at the optic nerve. The indirect ophthalmoscopy has such a low magnification that it really is not a great tool either for looking at the optic nerve. We should use a neutral density filter to keep the patient comfortable during the nerve examination. And there are several different lenses that one can use. I use a 60 diopter lens only because I like the fact that I don't have to correct for the size of the optic nerve. Now, having said that, I don't really measure the optic nerve all that often. So if I use the little device on the slit lamp at the arrow here to change the height of the slit beam, and it measures 4 millimeters, then that's the size of the optic nerve. I think the view with all of these lenses is similar, and I really wouldn't encourage one over the other, but just decide which one you like. I've used all 3 of them, and I think they're pretty similar. This is one of our house staff who's just barely dilated, but this is with the 90 diopter lens at 10x. You can see it uses slit beam here, a nice pink healthy rim, generous cup. I go to 16x, and just to compare that with the view with the 60 diopter lens, the 2 extremes, and it's really not that different. I actually had this videotape with all the different lenses, and I realized after a while that they didn't look that much different. So pick a lens that's comfortable for you. Carefully describe the size of the cup relative to the size of the optic nerve. This is a cup to disc ratio, and it may be different horizontally and vertically, and if so, you could list it that way, 0.5 by 0.7. It is helpful to draw the optic nerve, and I must say that with the electronic health record, it's much more difficult to draw the optic nerve, at least in the record that we have. There are challenges to looking at the optic nerve. A small pupil, that's better these days than it was in the era of pilocarpine. Some patients have tilted optic nerves, like this patient, much more common in people who are highly myopic. Or things like optic nerve head drusen can make evaluation of the nerve head almost impossible. So the normal optic nerve is slightly vertically oval. It's usually 1.5 to 2.2 millimeters in diameter. The nerves are typically symmetrical, like in this patient. There's a nice pink healthy rim of nerve tissue, and then there's a center excavation called the cup. But there's a wide variability in the size of the optic nerves, up to a 6-fold difference in area of the optic nerve between individuals, and I'll show an example of that later in this talk. And therefore, there's also wide variability in cup-to-disc ratio even among normal eyes. So the usual cup-to-disc ratio is 0.1 to 0.4. Some individuals have no cup, and 5% of normal eyes have a cup-to-disc ratio that's greater than 0.6. People of African heritage have larger optic nerves on average and larger cup-to-disc ratios on average than Caucasian Americans. So there are 5 major things to think of that are changes that occur in glaucoma. Large cup-to-disc ratio, progressive optic nerve head cupping, vertical cupping, asymmetric cupping, and disc hemorrhage. We'll go through each of these in detail. So large cup-to-disc ratio is the most common change that's seen in the optic nerve in glaucoma, but it's also the least specific. There is, as I said just a minute ago, tremendous variability in the size of the optic nerves. So these are 2 nerves from 2 different individuals. Very large nerve on the left side of your screen in someone who also has glaucomatous damage. Very tiny nerve on the right side of your screen. You can see the disc area in these 2 eyes, again 2 different individuals, are 3-fold different in size. So some very large nerves can have very large cups and still have abundant rim tissue. This is a patient with large nerve, large cup, but normal nerve fiber layer. And vice versa. So one can have a very small nerve and a small cup, but still have significant nerve fiber layer loss. It's just difficult to see. If one has a cup-to-disc ratio over 0.6, that should get your attention that this may represent glaucoma, because again, that's less than 5% of the population. I think it's always reasonable to get baseline photos. You never kick yourself for getting photos, but you'll often kick yourself for not getting photos. So these are large cups in a patient without glaucoma, pink rim all the way around. This is a large cup in a patient with glaucoma, very deep cup. You can see that the vessels dive in to this cup at the border. And this is a totally cupped optic nerve in a patient with advanced glaucoma. Progressive cupping is really, by definition, glaucoma. So in glaucoma, the pink rim of the optic nerve becomes thinner and thinner, results in a larger cup. So this little cartoon, patient with a 0.3 cup goes to 0.5, maybe gets some verticality to the cup, thin inferiorly. Now it's 0.7 by 0.9, and then totally cupped out. I always say it's sort of like describing a donut based on the donut hole. I mean, it's a little weird, but it's effective to talk about the cup in patients with glaucoma. The effect of the visual field is that this person should be normal, and they can lose a lot of tissue, still be normal. Now starting to get superior nasal field loss, superior and inferior field loss, and then blind. So just some examples of progressive cupping. This is 1978 on the left, 2003 on the right. You can see in here that the nerve is more cupped, and we'll show this picture again as an example of bearing of the circumlinear vessel. Really dramatic cupping that's occurred in this eye over the course of 30 years. See how the rim has become thin, the vessels are now diving in at the very periphery. A little bit more subtle, but you can see how superiorly this rim has become thinner. Vessels have been displaced. Patient photographed in 1968 and then again in 1989. Again, the rim has become progressively thinner. You can see there's a little disc hemorrhage there, which means that even the second photograph, the patient wasn't in great control. and really dramatic cupping here over the course of almost 40 years. So if we look at this, we can see obviously that the rim is much thinner everywhere. Therefore, the cup is much bigger. You can see the lamina here, which is a pretty non-specific thing. The vessels have been moved more nasally, which is another sort of subtle sign of glaucoma. This vessel that used to come in like this, all the way in over this rim tissue, now just dives and buries itself, bayonets. This is a young woman with mycelial glaucoma. She's now, at least in 2014, was 24 years old, and unfortunately didn't return for follow-up, only periodically, and you can see the dramatic change in her optic nerve that's occurred over only 8 years. Vertical cupping, which can lead to notching, is another sign of glaucoma. So the superior and inferior poles of the optic nerve are more sensitive to glaucoma damage. So a very vertically oriented cup is more concerning than a horizontally oriented cup. If very thin, then the rim is considered to be notched. Sometimes this takes on the appearance of an acquired pit, a term that I don't particularly like, but to me just means a very deep notch at the pole of the optic nerve. These focal changes in the optic nerve, as opposed to diffuse cupping, are somewhat more characteristic of damage that occurs in normal intraocular pressure range, normal tension glaucoma. So this is a patient with subtle vertical ovality to the optic nerve. More striking here, and you can see inferiorly how very thin the nerve fiber or the neuroretinal rim is right there. This is an interesting patient because she has such distinct focal cupping right here in the right optic nerve, and then both above and below, which is sort of unusual in the left optic nerve. And she is a patient with normal tension glaucoma. There is this rule called the isn't rule. I find that that's not helpful for me, and I think as an ophthalmologist, probably you would be studying the optic nerve to look for vertical nature of the cup, thinning of the rim. But it's a rule that I often will teach the family medicine residents and medical students because it's pretty easy to remember. So the inferior rim should be thicker than the superior, which should be thicker than the nasal, and the thinnest should be temporal. So that's the isn't rule. Again, I don't think that as someone who's an ophthalmologist, you'll probably be using that too much. Asymmetric cupping is really one of the easiest things to see when trying to identify someone with glaucoma. Your nerves, just like your feet and hands, should be pretty symmetrical. And an asymmetry of greater than 0.2 is pretty rare. It's less than 1% of the population. You would want to look for causes of unilateral glaucoma, exfoliation syndrome, angle recession from trauma, things like that. So a few asymmetric nerves here. The nerve on the left, the left optic nerve on the right side of your image, has a horizontally oval cup, pretty healthy looking. The right optic nerve has an inferior notch, and superiorly has a hemorrhage, and actually you can see a nerve fiber layer defect streaming off of that hemorrhage. This is a patient with severe trauma to the left eye. You can see totally cupped versus a normal nerve on the right. And look at the difference in the nerve fiber layer between the two eyes. And one of the things that you notice is the eye that has no nerve fiber layer, the blood vessels stand out so much more distinctly than they do in this patient's right eye. And this is the OCT of that patient, just showing the very thin retinal nerve fiber layer that goes along with all this cupping. When you see asymmetry of the cup, you should look for asymmetry in the nerve size, because that can occur. This patient clearly has cup to disc asymmetry with a larger cup in the right nerve, but the right nerve is also larger than the left nerve. You can see the area of the right nerve is quite a bit larger than the nerve on the left, and actually the eye with more cupping has a thicker average retinal nerve fiber layer than the other eye. They're both normal. So look for asymmetry in optic nerve size when you see asymmetry in cupping. And then lastly, disc hemorrhage. Some people call this Drance hemorrhage because Stephen Drance described this and really made us start to think about these as being important in glaucoma. They're especially seen in normal tension glaucoma. To me, they're a sign of active disease. They will resorb with time, but studies such as the OATS study have shown that having a disc hemorrhage portends a worser prognosis. Just a few examples of disc hemorrhages. You can see the flame-shaped nature of this because the hemorrhage is in the nerve fiber layer here. This image on the left, you can see a deep hemorrhage just inside the optic nerve. And kind of unusual patient with 2 disc hemorrhages. Sometimes these are really subtle, and as I've mentioned, that in the OATS study, hemorrhages were seen most times only on photograph and not on examination. This is a patient who has a subtle disc hemorrhage that is seen best when comparing to previous photographs. You can see that there's a hemorrhage right there, and it extends a little bit here. So it's probably a hemorrhage that's now in the process of resorbing. So there are other changes in glaucoma that I don't personally spend a lot of time thinking about. You probably should know about these. Peripapillary atrophy. There are 2 forms of peripapillary crescents. There are beta, which are white areas where the RPE doesn't reach the optic nerve head. These are white. And alpha, dark areas of thickened RPE, which are typically gray or black. Having a beta zone is more common in glaucoma, but they're present in 25% of the normal population. So having an area of beta atrophy is associated with glaucoma, and they can enlarge. So these are just a few examples. This is 1999 on the left, 2008 on the right. You can see that there's been increased cupping, but there's also been an increase in peripapillary atrophy. And a much more dramatic example, again, over a very long period of time, showing this. Now, I must say that I don't really follow the peripapillary atrophy clinically. I'm more interested in the nerve and the rim and the cup, but it is something that does change and it can be followed. Bearing of the circumlinear vessel, we showed this before. The vessel lining the cup can become exposed as the rim thins. I don't ever look for this personally, but it is something that's listed as a change that occurs in glaucoma. And also bayoneting, where the vessels crossing the rim disappear into a deep cup. Seeing a lamina fibrosa means that one has a very deep cup. It's not specifically from glaucoma. It can be a physiologic, very deep cup, so a non-specific change. Now, if one has a non-visible lamina and then develops a visible lamina, then that would be suggestive of glaucomatous damage, because the view of the lamina shouldn't change in a normal eye over time. One can have reversal of cupping. I think in adults this doesn't happen a lot. This is a subtle example between the picture on the left and the picture on the right, where the nerve does look actually somewhat more healthy in an adult with a profound lowering of the intraocular pressure. This is much more common in children. This is a 10-year-old boy who had pressures that were very high at the time of the photo on the left and then dropped to the normal range, and you can see marked reversal of cupping. We'll talk about the retinal nerve fiber layer. I just love this picture that shows the myelinated nerve fibers at the temporal raphe. This is a normal eye, normal nerve, in which the nerve fiber layer is really beautifully visualized in this photograph. In glaucoma, one can have damage to the nerve fiber layer. So you can see a little bit of a hemorrhage here, and then this defect in the nerve fiber layer right there. I must say that in my practice, I almost never saw these in Kodachrome slides, but now that we're doing digital photography, I see them very commonly, and I really can't explain why that is. You can see this defect in the nerve fiber layer quite visible here. And this patient has a broad swath inferiorly and a smaller one up above that are missing. Another example where there's a defect in the nerve fiber layer here and a hemorrhage at the border of the optic nerve. And this is somebody over time, so you can see in the left image fairly large optic nerve, but nice looking nerve fiber layer, and then on the right the cup is definitely much larger than it was in the left. There's a disc hemorrhage here, and then there's this wide swath of missing nerve fiber layer. So red-free light is supposed to help see these. I must admit that I don't use the red-free light personally, but some people do and find it to be helpful. You can see a defect here. As I said, with modern photography, I really find that I'm seeing these quite well on fundus photos. Now let's close by talking about optic nerve fiber layer analyzers. These have become very important in the practice of glaucoma. In our world of glaucoma, there are basically three forms: confocal scanning laser ophthalmoscope, scanning laser polarimetry, and optical coherence tomography. So confocal scanning laser is the Heidelberg retinal tomograph, or HRT. It determines three-dimensional anatomy of the optic nerve head and surrounding structures, and determines whether these findings are normal or abnormal. This is an HRT of a patient of mine showing that the nerve is fairly normal, large cup. It'll hit at the bottom here, give us the disc area, cup area, rim area, cup volume, lots of other parameters about the anatomy of the optic nerve. And it has algorithms to detect change. So this is somebody who has had 2 exams separated by 31 months, and you can see areas of improvement and areas that are changed. There's a suggestion here that this part of the optic nerve is thinner. I think HRT at the time it came out in the early 2000s was really revolutionary. It is used much less commonly today because of OCT technology. Scanning laser polarimetry is based on the polarizing nature of the retinal nerve fiber layer that retards reflectance of light. Unfortunately, the cornea also has polarizing effects, so the signal needed to be corrected for the cornea, and this was the basis of a device called the GDX. And I can't really find that this is available anymore. I certainly haven't seen a GDX scan in many years. So probably important that you know that it existed and know that it's based on this scanning laser polarimetry, and that the cornea has an effect on scanning laser polarimetry. Ocular coherence tomography, or OCT, has really taken over most of the world of looking at the retinal nerve fiber layer, and more recently looking at the nerve. Based on interferometry, there are many instruments that are currently available made by many manufacturers. There's time domain, spectral domain, swept source. It is a rapidly evolving field. And we can use it to evaluate the retinal nerve fiber layer, also the ganglion cell layer and the macula, as well as the optic nerve. This is a Cirrus printout. I don't have any particular feelings about Cirrus versus Stratus versus others. This just happens to be what I have. This is a normal eye. You can see that it gives you a map of the optic nerve up above. It will tell you the cup to disc ratio, which is quite small in this patient, the average retinal nerve fiber layer thickness, and you can see the nerve fiber layer thickness down here. And it gives descriptions of how normal that is with the color scale down below. This describes the thickness of the neuroretinal rim of the optic nerve. Really a lot of data on this sheet. This is a patient with glaucoma, kind of stepping through the exam and what we see. So at the bottom, it has a retinal nerve fiber layer thickness. You can see an area superiorly that's very thin, and that's reflected in these the difference from normal being red. Less than 1% of people should have that much thinness there. You can see a deviation map that maps out this superior defect in the retinal nerve fiber layer. A drawing of the nerve fiber layer thickness. You can actually see defect in the nerve fiber layer in this drawing. And then all of the data. So it shows the average retinal nerve fiber layer thickness at the top, how symmetrical this is. It's not symmetrical. The rim area, disc area, cup to disc ratio. So in this patient, and it just all fits together. You can see that there's this superior arcuate defect that shows up in the deviation map and the thickness map, and also shows up in the retinal nerve fiber layer map, and it is reflected in this inferior nasal defect. There is now progression analysis that can be used to show that this patient is losing superior nerve fiber layer over the course of time. And there are many other statistical ways of looking at this: the average retinal nerve fiber layer thickness, the cup to disc ratio, etc. You can see here filled in areas where there is significant change in the retinal nerve fiber layer thickness profiles. So I want to get too much in detail about how to interpret an OCT. I think depending on where you are and what machine you have available to you, you need to determine an expertise in this, but being able to look at the retinal nerve fiber layer has been a game changer in glaucoma. We've always been able to look at the nerve, and we've always been able to look at the visual field, but now this is something different, another way of looking at the health of a patient, and it's a really impressive and useful technology that's rapidly changing. Same device will allow us to look at the macular ganglion cell layer, which is, we're starting to realize more and more, is affected in glaucoma. We used to think that it was relatively preserved. So this is a patient who has thinning here temporally in the optic nerve. They have a defect in the visual field, right at fixation. When we look at this patient's OCT, really doesn't look that bad. The retinal nerve fiber layer thickness has one little area that's thin, but overall not startling. But when we look at the ganglion cell layer of this right eye, you can see that it's very thin, and that's reflected in this 10-2 visual field showing substantial loss. So over time, we're becoming more aware that the macula is not protected in glaucoma, and the ganglion cell layer analysis is very helpful in looking at this. So these imaging technologies are spectacular, and I definitely use them every day in my practice. But despite that, there's definitely a role for photography. It's non-variable technology. So I showed these pictures earlier. This is 39 years of follow-up. And just imagine what your 39-year-old retinal nerve fiber layer analyzer is going to look like 39 years from now. It's going to be pretty much useless to you because that technology will have gone through dozens of changes. But photography is photography. The one in 2015 taken with a digital camera, the one in 1976 taken with Kodachrome, but you can still compare them. And so I would encourage you to continue to get optic nerve head photographs. Remember, disc hemorrhages are much more easily seen than the slit lamp. In OATS, 84% of hemorrhages were seen only on photos. When in doubt, take a picture. You'll never regret taking a picture. So a long talk, but the key points are that you should become an expert at examining the optic nerve, looking for the major signs of glaucoma: large cup to disc ratio, progressive optic nerve head cupping, vertical cupping, asymmetric cupping, and disc hemorrhage. And now, thanks to new technology, the retinal nerve fiber layer is another feature that we can follow. In whatever device you have at your institution, you should become comfortable and expert at using that.